Next speaker is Dr. Richard Chaisson. He is a professor of medicine at Johns Hopkins University School of Medicine and the director of Johns Hopkins Center for Tuberculosis and Center for AIDS Research. He is an annual chair of a TB-THG within AIDS clinical trial group, and he is a principal investigator of many landmark TB studies. Today, his topic is on update on TB treatment and challenges. So please welcome Dr. Chaisson.
Thank you very much, Dr. Sivaporn, and my deep thanks and gratitude to Professor Prapan for his invitation to join you here today. I'm delighted to have the opportunity to be here. I'll disclose my relationships and funding sources. So I want to start by just setting the stage with the epidemiologic situation of TB that we heard about at the opening of the session. The latest report from the World Health Organization showing 10 million incident cases of tuberculosis, and about 10% of those are in people with HIV, 1.5 million deaths from tuberculosis in 2018, and closer to 20% of deaths are in people with HIV. And HIV-related TB, as I'll show you, is an important cause of mortality in people living with HIV than dying of TB. And then drug-resistant TB, 500,000 cases, and very high case fatality rate because of inadequate therapy. TB incidence over the past couple of decades really hasn't changed very much at all, despite all efforts by the global TB community to eliminate tuberculosis. The number of cases in people living with HIV has declined slightly, but only slightly. But if we look at mortality, mortality in people with HIV remains substantial. Over 30% of deaths of people with HIV are due to tuberculosis. And tuberculosis eclipsed HIV as the leading infectious cause of death on Earth several years ago. And even if you exclude HIV-related tuberculosis deaths, there are still more deaths from tuberculosis than there are from HIV and AIDS. And as it's been pointed out by many observers, it's not a contest to see which is worse, but it's clear that tuberculosis has remained a major cause of morbidity and mortality that has been refractory to interventions to control it. Now, the World Health Organization, the United Nations General Assembly, and the Stop TB Partnership have set very ambitious goals for eliminating tuberculosis or ending the TB epidemic. And by 2030 or 2035, depending on which guideline you go by, the intent is to have a 90 to 95% reduction in TB mortality, 80 to 90% reduction in TB incidence, and have nobody anywhere on Earth suffer catastrophic economic consequences from having tuberculosis. So these are quite ambitious goals. Some might even call them delusional. How are we doing with progress towards these goals? Well, there are interim targets that were set within these goals. These are the 2020 targets. We're in 2020, and our progress towards achieving those targets is terrible. We've really done a bad job at meeting those targets. So there's a lot more work to do. And what do we need to do to end the TB epidemic with the tools that we have and with the tools that need to be developed to improve our response? Well, this is a strategy for approaching the TB epidemic globally. It's very simple, but it's based on the epidemiology of tuberculosis and the interventions available. So the first thing we have to do is find the tuberculosis that's out there. Our case detection rates remain inadequate. We're missing about a third to 40% of tuberculosis cases globally. And relying on passive case detection isn't sufficient. So we need better diagnostics, and Dr. Koblenz has just discussed very nicely a lot of progress being made in that field, but the translation of that laboratory work into public health will remain a huge challenge. We need to treat TB once we find it, and we need better therapies for treating tuberculosis so that we cure most patients, and we can treat multi-drug resistant and extensively drug-resistant TB, for which current outcomes are really abysmal. And then most importantly, we need to prevent TB before it happens. The TB case that doesn't occur is a non-event, and we really have to do a better job of targeting preventive therapy at the people who are at highest risk of becoming a TB case. And again, Dr. Koblenz talked about some new technologies to identify those people more efficiently, but we really need to implement those technologies and provide treatment where it's indicated. And ultimately, a new vaccine will also contribute to TB control through prevention. So let's get into TB in people with HIV and the challenges that you all face as clinicians and program directors taking care of patients. Well, first of all, diagnosing TB in people with HIV can be very difficult. The diagnosis has to rely on clinical and epidemiologic grounds as well as laboratory tests. And the most important thing that is omitted in evaluating people who have HIV-related TB is thinking of TB. And doctors and clinicians don't think about TB when they really should, particularly where epidemiologic risk factors are present. And HIV is about as strong an epidemiologic risk factor for TB as exists. And then there needs to be an appropriate laboratory evaluation with the rapid diagnostic tests, including rapid molecular tests. It's very appropriate to give presumptive therapy while awaiting a diagnosis. If we delay treatment because we're not certain of the diagnosis, the patient can die. Extrapulmonary TB is common, and that can be challenging both for treatment, for diagnosis and treatment. And then the timing of antiretroviral therapy is an important consideration relating to the CD4 count of the patient who has a TB diagnosis. Managing drug-drug interactions is challenging. Dealing with immune reconstitution, inflammatory syndrome, or IRIS can be challenging. But the biggest challenge, I think, is prevention. We don't want to have all these drug-drug interactions, IRIS, timing of ART. We don't want the TB to occur in the first place, and we really have to prevent it. So there's been no change to the treatment of drug-susceptible TB in the last 30 years. And these are the latest guidelines from the American Thoracic Society, CDC, the IDSA, and the American Academy of Pediatrics. They might as well have just reprinted the ones from 15 years earlier. There's really no change. The only thing I would emphasize is that for people with HIV, daily therapy is essential. Intermittent therapy is associated with poorer treatment outcomes and the emergence of drug resistance. So for people with HIV, daily treatment of tuberculosis with the standard 4-drug regimen is required. And short course treatment works for people with HIV if it is delivered appropriately. But even when treatment is delivered appropriately, and these are data from a large number of phase 3 clinical trials of anti-TB drugs, people in the control group treated with the standard of care had significantly poorer outcomes. They were threefold more likely to have an unsuccessful treatment outcome than people without HIV infection in these clinical trials. So why is that? Well, there are a couple of reasons for that. Some of it has to do with the use of intermittent therapy in these trials. They didn't all use daily therapy. Some of it has to do with non-adherence because of toxicity in people with HIV. And a lot of it has to do with the provision of antiretroviral therapy to these patients. Now, we know from a number of very nice clinical trials conducted more than a decade ago, by and large, that giving antiretroviral therapy during TB treatment is essential and overall reduces the risk of death by about 25%. So we have to treat patients with ART while they're being treated for TB, not wait until it's completed. The timing generally is at 2 weeks, at least within the first 2 weeks for people with very low CD4 counts, and within 2 months for people with higher CD4 counts. And when this is done, not only do we reduce mortality, but we reduce progression of HIV disease and the development of new opportunistic complications. So everybody seems to know this and has known this for quite some time, but there remains a huge gap in providing antiretroviral therapy to people with HIV-related TB. These are the data from the last global TB report. And in the black line, you see the report of people with HIV-related TB who are known about and reported to programs, and the uptake of ART, shown in the blue line below, is very high, so that's very good, but that's what's reported. But what's not reported is this huge gap of people with HIV-related TB who aren't properly diagnosed, who don't get an HIV diagnosis, and don't get antiretroviral therapy. So we have important progress that needs to be made with making sure that everybody gets diagnosed and put on ART. So how do we treat patients with TB on TB therapy with ART? Well, the standard that has emerged is an NNRTI-based regimen with efavirenz. Efavirenz and rifampin can be given together without any compromise to the antiretroviral activity of the regimen. The CDC and other groups recommend the standard dose of 600 milligrams, but there are PK data that show that the 400 milligram dose can also be used with rifampin. For a number of years, a number of people used rifabutin instead of efavirenz. It required a dose increase of the rifabutin to a higher dose because of an interaction of efavirenz and rifabutin, and it caused toxicity, uveitis, and other complications. And the question is, why would you use rifabutin when rifampin is much cheaper, more easily available, and perfectly good? So there's no reason to demand rifabutin for people receiving efavirenz because it's completely unnecessary. The emerging standard is an integrase inhibitor-based regimen. Dolutegravir can be done at a twice daily 50 milligram dose. I accidentally labeled this the aspiring. It's the inspiring. When they were doing the study, they were aspiring, but when they completed it, it was inspiring, and I'll tell you about that in a moment. The Reflate study showed that rifampin can be used with raltegravir, but that the dose should really be 800 milligrams twice daily. You can use rifabutin again, but again, why would you? Why would you bother when it's not necessary? And for those individuals who can't be treated with an integrase inhibitor or efavirenz and really need a protease inhibitor, then that is a situation where rifabutin can be used, although the toxicity can be a really major limiting factor, or you can double dose lopinavir, ritonavir with rifampin, but again, toxicity can be a real problem. There's been a lot of research on drug-drug interactions, and this is just a summary of some of the recent trials. I won't dwell on them too much, but I want to emphasize inspiring and recent studies with TAF. But by and large, most of the news out of these studies is good, that we can manage the drug-drug interactions with antiretroviral agents and rifamycins. So this is the inspiring study. The inspiring study randomized individuals with HIV-related TB and CD4 counts above 50 to either dolutegravir twice daily regimen or the standard efavirenz-based regimen, and then followed them up for a year. And what you see is that there was no difference in attaining virologic suppression. There's a faster clearing of virus with the integrase inhibitor, as you would expect. But overall, at a year, viral suppression was about 90% in both groups, and treatment outcomes for TB were excellent in both groups. So the 50 milligram twice daily dose of dolutegravir works well with rifampin-based TB therapy and can be used. PEPFAR is making 50 milligram single tablets available for use with TLD in individuals in high-burden countries. What about TAF? There is a comment in the FDA label for TAF that TAF shouldn't be used with rifampin, because rifampin lowers TAF concentrations. In this PK study done in healthy volunteers, however, what was shown is that there was a reduction in the TAF concentration, a rather substantial reduction in both the trough level and in the area under the curve, about a 50% reduction in the area under the curve. Nonetheless, the intracellular levels of the active component, the tenofovir diphosphate, decreased by about a third, but that's fourfold higher than the exposure you get with TDF with no rifampin. So there's no worry that you're going to compromise the effectiveness of TAF by giving it with rifampin, and this really can be used. One of the downsides of giving antiretroviral therapy is the risk of IRIS, and again, from the meta-analysis, the risk of IRIS is increased when people with active TB receive ART. But the benefits in terms of mortality and disease progression clearly outweigh the risk of IRIS. Here's an example of a case of IRIS in a young man with HIV-related TB, a very low CD4 count, which is one of the important markers for the risk of IRIS. And after 2 months on therapy and 6 weeks on an efavirenz-based regimen, he developed a very hot supraclavicular lymph node that was necrotic, had to be excised in the operating room, and turned out to be IRIS. It was culture negative. Last year, Graham Menkes and his colleagues from South Africa reported that IRIS can be prevented in high-risk individuals by giving prednisone, and these are the results of their study. You can see a reduction in the risk of IRIS of about 15%. The disappointing part of that is giving prednisone 40 milligrams a day for 2 weeks, followed by 20 milligrams a day, only led to a modest decline in the incidence of IRIS in these high-risk patients. And so it was significant, but there's clearly still a need to have better therapies to prevent IRIS, and there are a number of studies looking at that. In terms of drug development for HIV-related TB, shortening the course is important, improving MDR treatment is important, and then prevention of both MDR and drug-susceptible TB are high priorities. Data from a TBTC study showed that high-dose rifapentine really sped up the time to culture conversion significantly using very high doses of rifapentine. And that's led to this clinical trial, Study 31, ACTG 5349, that's looking at a shortened course using high-dose rifapentine with or without moxifloxacin. A number of patients in this study were enrolled here in Thailand, and we expect to have the results of this in the next few months. So stay tuned for that. Outcomes with XDR-TB and MDR-TB are really terrible. These are outcomes for XDR-TB in South Africa with 80% mortality at 5 years. So we really need much better interventions for drug-resistant TB, and the good news is there are a number of things in the pipeline. The STREAM study was recently reported in the New England Journal, and this is the Bangladesh regimen, a 9-month regimen, a short regimen compared to the standard of care. And they used high-dose moxifloxacin instead of gadifloxacin. And what they found was that successful treatment with this short regimen, the Bangladesh regimen, was the same as with the longer old regimen and was shown to be non-inferior and worked equally well in people with and without HIV. This is the Bangladesh regimen. Who on earth would want to take that? It's a really terrible regimen. We really need to do better, and it's reminiscent of the old days where HIV therapy looked like the Bangladesh regimen, and we demanded, and our patients demanded, better regimens, and we got them. So what are the drugs that might improve treatment for drug-resistant TB? There are a number of new products, bedaquiline particularly, protamidine and delaminid, and then some old drugs that have been repurposed like linezolid and clofazimine. Recently, the Food and Drug Administration approved this regimen, including protamidine, for patients with extensively drug-resistant or refractory MDR-TB. Protamidine, bedaquiline, and linezolid given for 6 months, and they achieved a 90% success rate with this regimen. Small, uncontrolled trial, nonetheless, compared to all other experience with XDR-TB. This is really spectacular, and it performed equally well in people with and without HIV infection. So this really could be transformative for drug-resistant tuberculosis, and suggests that bedaquiline might become an important drug for the treatment of drug-susceptible TB. It may shorten therapy. Well, what about prevention? We clearly have to prevent TB, and the two strategies for doing that are universal antiretroviral therapy and much wider use of TB preventive therapy. The START study showed that early ART compared to delayed ART reduced tuberculosis by 70%. So just giving ART reduces TB by 70%. They didn't give preventive therapy for TB in this trial. What about at a population level? Does universal ART result in a reduction in tuberculosis? So in the last few months, there have been 4 reports of population-based ART scale-up in Africa in cluster randomized trials. These 4 trials failed to show a very impressive impact on HIV incidence and prevalence, only modest effects on HIV. But the SEARCH study in East Africa actually looked carefully at tuberculosis incidence, and what they found is that in the intervention communities where ART was scaled up broadly, there was a significant reduction in tuberculosis incidence without any other intervention. So this is extremely promising, about a 60% reduction. Now, if you combine antiretroviral therapy with TB preventive therapy, you get further improvements. These are data from the TRIO study in Rio de Janeiro, where ART was widely available and free, and what we did is we went in and added TB preventive therapy targeted at people with positive tuberculin skin tests, and over a 5-year period, that resulted in about a 25% reduction in the risk of TB and a 30% reduction in the risk of TB or dying. So putting TB preventive therapy and ART together is very potent. And the Temprano study reported subsequently from West Africa also showed that giving IPT to people with high CD4 counts reduced their risk of progression to AIDS or death and reduced the risk of TB. But if they got ART and TB preventive therapy, they did the best. They subsequently reported that IPT, INH preventive therapy, reduced the risk of death by almost 40% over 5 years, independent of antiretroviral therapy. But as you can see on the right-hand side, the lower bar is the group that got both early ART and IPT for 6 months, and they had the best outcomes. So the combination of isoniazid preventive therapy, TB preventive therapy with ART is the best strategy that we have for reducing rates of tuberculosis in people with HIV. So I'm not telling you anything that I couldn't have told you 10 years ago when I was last here, not at this conference. But what's happening globally? What's happening globally is the uptake of preventive therapy has been horrendously poor. In the last year, the WHO reported a sharp increase. This increase is probably more on paper than it is in the clinic. Nonetheless, it's only a fraction of the people who should be getting TB preventive therapy, people with HIV. It's about 6% of the people who are eligible for it. So we've really done a terrible job. So what do we need to do to make it better? Well, we need to make preventive therapy easier. So over the last 2 decades, there's been a lot of work looking at short regimens that are easier to administer, that are safer, and can be more easily deployed. So studies of 3-HP, rifapentine and INH, 12 doses over 3 months, showed that it was either non-inferior or superior to INH. It was safer than INH and has better adherence and treatment completion, and so this is a strategy that needs to be rolled out. One of the questions that's come up recently is, can you give 3-HP to people on dolutegravir-based ART, since dolutegravir is being rolled out globally as the preferred antiretroviral regimen. So we did the Dolphin study to look at this in people on a dolutegravir-based regimen. And what we showed is that the co-administration of normal dose dolutegravir, 50 milligrams once daily, with 3-HP did result in a reduction in the trough and AUC levels of dolutegravir, up to a 50% reduction in the trough level and about a third reduction in the AUC. But the levels remained well above the IC90 in all individuals, and all individuals remained virally suppressed while receiving 3-HP. And so the co-administration of 3-HP and dolutegravir standard dose can be done. We're about to begin Dolphin 2, which will look at people starting a dolutegravir-based regimen, ART naive, and getting 3-HP at the same time. Can we do better than 3-HP? These data from the mouse model of TB show that a 1-month daily regimen of rifapentine and isoniazid is as effective as the 3-HP regimen. That led to the BRIEF TB trial done by the ACTG and the IMPACT Network, multi-center trial in people with HIV, adolescents and adults, who got 1 month of rifapentine and INH daily versus 9 months of INH. This shows you baseline characteristics, and a couple of hundred patients were enrolled here in Thailand. And the outcome was that this 1-month regimen was equivalent to, non-inferior to, the standard 9-month regimen of isoniazid in people with HIV. It's important to emphasize that most of these patients also received antiretroviral therapy. 50% were on an efavirenz-based regimen when they began, and by the end of enrollment, that was up to 93%. The regimen also worked very well in individuals who had a positive tuberculin skin test or IGRA test at baseline, which wasn't a requirement. The World Health Organization recommends preventive therapy for all people with HIV regardless of tests, but we showed in the subset of people who did have a positive test, it was just as effective, non-inferior. And this shows the time to a tuberculosis event. We also found that daily HP could be given with an efavirenz-based regimen without affecting efavirenz concentrations and performance of the efavirenz regimen. A trial is getting underway in the ACTG shortly to look at 1-HP and dolutegravir, and those results will be eagerly anticipated. All right, so there are lots of options for TB preventive therapy in people with HIV. Drug-drug interactions are a consideration, but as I've shown, by and large, we can successfully manage patients on TB preventive therapy and ART. The World Health Organization has recommended the 3-HP regimen in its latest guidelines, and those will be shortly updated to include the 1-HP recommended for people with receiving efavirenz-based regimens. So we have lots of options for preventing TB. So let's get back to our global strategies and the NTB targets. Are these aspirations or are they delusions? Well, as I showed you, right now, the aspirations seem delusional because we've done such a bad job of treating our patients and getting people onto TB preventive therapy. I've called this TB preventive therapy denialism. We all heard about AIDS denialism from Thabo Mbeki in South Africa and the hundreds of thousands of lives that were lost because of AIDS denialism. Well, we as a community have had TB preventive therapy denialism. There's an error in the slide. It's 12.5 million deaths from HIV since 2009, when the WHO first recommended TB preventive therapy for all people with HIV. We know from Temprano that 37% of AIDS deaths can be prevented with preventive therapy. So are we responsible for 4.5 million deaths that could have been prevented because we don't use TB preventive therapy? I think we really have to consider the culpability of the HIV community in letting this happen. But thinking about delusions, you all might remember 3 by 5. Back in 2001, the World Health Organization said, we need to put 3 million people on ART by 2005. Everyone thought that that was completely idiotic and delusional. There was no way that you could do it. But in fact, the world really rallied around and didn't quite hit 3 million by 2005, but came very close, and as you can see, has continued to scale up, and now about 25 million people around the world are receiving ART. So you can achieve delusions with global action and mobilization and commitment from political leaders, from funding sources, and from the community itself. Nelson Mandela here in Bangkok, at the Bangkok AIDS Conference, said, the world has made defeating AIDS a top priority, but TB remains ignored. Today, we're calling on the world to recognize that we can't fight AIDS unless we do much more to fight TB as well. These are very prophetic words that he said 15 and a half years ago. But I think despite the neglect that TB has received over those 15 and a half years, we really can heed his words, follow his message, and get TB on track to being eliminated and reach the TB NTB goals that have been so boldly set out. And with that, I'll end, and thank you very much.
Thank